if we can harness the power of biology to help augment any of our surgeries, I mean, I think that's where the future of our field is clearly heading. In the future, or now, we can do things to get the ACL tunnels to heal better, or that tendon that we put in to become a ligament. Or if we have more reliable ways to take the meniscus repair healing rates from 80%, which is okay, if we can give it a biologic boost with PRP or the like, then I think that that's really where the future lies. And that's the promise of orthobiologics in sports medicine.
When's the last time you really thought about your knee health or wondered if the shoulder twins could sideline your workouts longer than expected? Today's guest knows a thing or two about keeping joints in top form. Dr. Seth Sherman is a third-generation sports medicine expert, physician for the Stanford University football team, and an orthopedic innovator specializing in knee preservation and cartilage restoration. From the Missouri Tigers to the Chicago Bulls to the Stanford Cardinal, he knows how to fix athletes. And now he's here today to share some game-changing insights. Welcome to the show, Dr. Sherman.
Thanks so much for having me. I'm excited to be here.
Awesome. So my biggest question, when I found you, I think it was on LinkedIn, reached out to you. Like my biggest question, I'm gonna come with the first question. So Perfect. Get ready for it. Buckle in. So in my mind, if I was going to be a physician, like working for a high-level sports team would be like the dream. I have that thought just because my cousin was an athletic trainer for the Iowa State Cyclones when we were both in college. And then he went on to work for the Dallas Cowboys for a couple of years. And then he moved back to Iowa for who knows why. But so just seeing him, all the experiences and the stories he had, I just thought that's the coolest thing ever. So like in your world with Stanford or, any of the other high level teams that you've been a part of, that's a dream. And if you're a young kid who dreams of being a surgeon for a high-level team or working for Stanford or whatever it may be, how can they take that path that can give them the best opportunity to live out that dream?
Yeah, no, it's a great question. And we try to inspire young people to, consider this field. And, interestingly, some of our Stanford athletes, want to pursue medicine and orthopedic surgery afterwards, which is a ton of fun also to guide them through. I'm a surgeon's son, as you said, a third generation. So I got the cheat sheet. I mean, I grew up on the sidelines in Brooklyn. It was high school football. It was Nathan's hot dogs. It was, fishing with my dad and grandfather. My grandfather was a general surgeon. My dad was an orthopod and the first in our family to do it. So, it just, I saw their passion. I saw the fun of it. And I saw, really the impact you can make, in these young kids' life, getting them safely back to sport. So for me, I was lucky, to have that. If you're not as fortunate, I think these days with, frankly, social media, internet, and, all sorts of sports and injury shows, and with everyone just being an athlete, that's a big draw. Like a lot of athletes or former athletes, are interested in medicine and specifically sports medicine. So that's probably how a lot of those others get into the field. Our field's all about mentorship. It's about bringing everybody up together. So, some fields really beat you down and beat down the system, and it's a grind. And ours really tries, I think, for those who I've levitated to through my career, to bring people up. I'm always having young learners in my clinics. You message or email me, undergrad, graduate, PT student, athletic training, of course, our residents and fellows. We want you involved. We want you there with us on the sidelines. And I think, that finding good mentors early is helpful. Shadowing people early. We even have some of the high school kids, who have a project idea and find us, message us like you did on one of the channels. And, we respond to that because we were that. And I think that that's important. So that's probably goes with sports medicine in general, the embracing of the culture of teamwork. Because team sports are, built upon people and people working together. And I think that mindset, specifically plays in what we do as well.
Yeah. You mentioned your dad and your grandpa being in the world that you're in now. Was there any other career that you considered growing up, or was it just you knew from a very young age, like I'm going to be an orthopedic surgeon, I'm going to be a doctor, I'm going to work with sports teams?
I was there at the right time as the grandchild who was really there when my grandfather was about to retire. My dad was coming up in sports medicine as an orthopedic surgeon. So for me, really not. I mean, I always loved teaching and learning, so I would have been a teacher if I wasn't a sports medicine surgeon. For a time when I was a real young kid, I loved and wanted to be a garbage man, of course, but I think a lot of us did.
Sure.
And that's an awesome job too. But teacher would have been probably a second, thought or choice, but we're always teaching and learning in our field. I think it was just really special timing to see my grandfather. They named the field after him at Lafayette High School in Brooklyn. After 50 years of free service, he always gave the money back to the school. He opened up his clinic on Saturday afternoons, and all the high schools would come because, there was nowhere else to get that kind of urgent, care at the time. So as a general surgeon, he really did that. And then basically, I think for him, selfishly, he wanted to hear the scores and hear the stories of all the games before the papers came out the next day too. But he wanted to take care of the community. So I think it served both purposes. It never seemed like work, I guess, is the point.
Yeah, it's just a different type of patient, right? I mean, you've worked with professional teams, college level teams. Like, what are some of those unique challenges when you're treating athletes compared to other patients?
Yeah, I think what's fun and exciting about sports medicine, orthopedic surgery, is that you really can dive into whatever subspecialty niche that you want, right? There's a subspecialty of mine, for example, which is really more failed sports medicine. When ACLs go wrong, when menisci are taken out, and now you're a active arthritic, and that's a totally different subset, maybe an aging or aged out athlete or military or former military or officer level. I mean, that's a different subset than our guys who are going to play on Saturdays or play on Sundays, where they're in peak performance now and really in tune with their bodies at the moment. And I think the way we counsel those people in their different scenarios is slightly different. And, some of the tools in the toolbox that we use for some of these salvage interventions are very different than some of the tools we might use to keep an elite athlete going in their prime for that, short amount of time. For example, we can't grow cartilage in most cases. That takes 18 months to grow and 24 months to get back when you're in a contract year, or if you have, only 1 year of eligibility left, or 3 months until you have to be in the Olympics, or, all sorts of different examples. So I think it's very individualized and very personalized medicine, which is a theme elsewhere, but it's truly a theme at the highest level of sports medicine. It's relationships, and it's kind of give and take.
Yeah, you bring up a good point, because what I heard you say is like there's preventative care and then there's more reactive care. The more reactive is going to be, cartilage breakdown, the, military or kind of, I don't want to say washed out athlete. That sounds better. I don't know what phrase you use. That's,
not that.
Later in their career athlete. Let's call it that.
Aging athlete.
Aging. That's what you said. An aging athlete. And so that's more reactive care to, deterioration of some sort. And then I got to imagine, with some of these younger athletes that are, playing on Saturdays, playing on Sundays, there's more preventative, you're being a little bit more proactive with the health of those things. Which of those two gets you more excited?
I love the preventive aspect in the young athletes. I think even just with young kids and their parents, educating them about things that we now know are important, like participating in multiple sports, cross-training, not just doing that one sport year-round. I mean, that prevents injuries, and that prevents burnout, and that promotes well-being, health, confidence, and frankly, many examples I'm sure you can think of people who are at the highest level of one sport later on, who really achieved that, started out as multi-sport athletes. The best basketball player in their community is also the baseball pitcher, in the MLB, for example. And that was my personal example of someone in Staten Island, New York. And, I think that holds true, right? So I love the ability to keep athletes well, and it's really challenging, and there are innate issues that come with that part of the training, and working with really good athletic trainers, physical therapists, and frankly, a lot of the new technologies are helping us so that we can really monitor their outputs and make sure they're not overdoing it. But, then you go to the other side of the coin, and then I have people like you and me who've had maybe 2 surgeries, can't really work or sit here doing this podcast because they're in pain, don't enjoy their family life, certainly can't play or do things that they used to do. And that's very different than being 0.1 millisecond from being the hoopster on TV that they were, right? Those are 2 different problem lists, none more important than the other. And in that patient, we basically do a retroactive kind of root cause analysis of the problem. What went right? What went wrong? What are the key issues and risk factors, things that we can chip away at? And it's really more about quality of life, daily life, low impact activities, things that everybody else takes for granted that they've lost. And for the athlete, it's, at this point in their life and career, or the military athlete, it's about performance. Are you ready to go? Right. So if you're not ready to go, then you're not going, you're sitting out. And then we kind of have to continue to work that problem set. So, that makes it interesting, engaging, and challenging nonetheless.
Yeah. That's interesting insight on being a multi-sport athlete and how that can help you. I guess I've never thought of it from the health side, like your joints and your muscles and everything just kind of stays. If you're just doing one sport, I got to imagine that the deterioration of muscle or ligaments and things like that eventually cause injury. If you're just doing one sport, you're more prone maybe to do that versus you're doing different movements. Like I know when I was in high school, I played football and basketball. I was okay at both, not nowhere, college or at pro level, but like, I never thought of it that way. And like, those are completely different movements. You're using a lot of different muscles in football than you would in basketball. I never thought of it that way. So that was one takeaway I got from that. And then when I think about the older generation, I think the question that comes to mind then is, as you're kind of diagnosing or understanding the injury that they have, how often does that come from poor treatment, maybe earlier in their life when the injury was actually sustained? There was just poor care then that has then led to future pain and ailment that now you're taking care of.
Yeah, I think as a tertiary care provider, we never frame it that way. It's not instructive to look backwards. It's always instructive to look towards the future and to help them in the here and now and beyond. And so, when we are identifying things that might or could have been done differently, we're not like pointing it out in that particular way. We're really, I think everything we do in our field is an evolution and we're learning. So, for example, we used to all take out the majority of meniscus tears, and that's now we know it's a major shock absorber and it shields the loads, and we should probably try to preserve it if we can. We can't do it all the time, but we try, right? And so ACLs, we used to put them in more straight up and down, and so maybe it didn't have the best stability, or we might have used different graft choices. And so seeing someone 10 years down the line, it's not necessarily about poor intentioned treatments that were suboptimal. It's well-intentioned treatments that are part of a spectrum. And so I think, patients and people just want to fixate on what went wrong. Why did it go wrong? Can we do? And I try to focus on what we can do different or better in the future, and really not, talk down or badly upon that other aspect.
Absolutely. What drew you to specialize in knees and shoulders? So kind of a 2-part question. What drew you to knees and shoulders? But then what excites you about, you were just talking about joint preservation and cartilage restoration. Like what is it about those 2 parts of the body that get you excited to get up every day and go to work?
I think when I was in med school, I tried, and in orthopedic residency, I tried to do a good job of giving everything its fair share time, meaning I probably treated, the internal medicine service like it was the Super Bowl, just like I treated, the ortho fracture service, and really came with that preparation mindset. And then I'm going to be the best med student and give the best presentation and, do my reading and show up for these patients, even though at the end of the day, I knew in my heart of hearts, I'm checking off boxes. This is not that interesting or passionate for me for my future. This would not be sustainable for 5 years, 10 years, 30 years. And so kind of did that to lead me into orthopedic surgery. And then in orthopedic surgery, there's many different avenues, right? You could do spine surgery. You could do purely pediatrics and all the things that are there. And, I think sports medicine in general, I think it's most of the time quality of life problems. So it's more about the attitude, mindset, patience. It's not in most cases, life and death. I mean, that's for our trauma colleagues and our ortho cancer docs, and they do God's work and they're fantastic. For me, I wanted to focus on really being impactful and, keeping people active, moving, keeping their quality of life together. And, I think knees and shoulders are really the backbone of a sports medicine practice. It's the most common things that we see and treat that are injured. Of course, we have the hamstrings, ankles, and hand and wrist issues that plague football and other sports. And I have great colleagues help me with some of those. And we do, of course, have expertise in the primary management of a lot of those things too. But when it comes down to surgery and surgical expertise, it's clearly, been knee and shoulder for sports medicine. That's kind of the two big ones. In the last decade, or probably more than that now, hips have become in vogue as far as, using minimally invasive techniques. That's what we do, using the camera, the small poke holes in the knee or shoulder. Arthroscopic techniques in those joints is typically, what we do. And that aspect of it, being able to really get in, get out, do your job, and affect change that influences function is really powerful. And that's probably why I'm so drawn to that. It's amazing to think that, for example, a less than 3 centimeter long little rope in the middle of your knee controls the destiny of that athlete for their entire life and career. Now, that rope's surrounded by a knee and a person and other people, so there's a lot to it, more than just putting in that little structure. But at the same time, it's got to start and end there, and being able to give them the pathway back by doing an ACL is super cool and really rewarding. What was the second part of your kind of question? So that was more knees and shoulders, and then
what excites you about working on joint preservation in the cartilage? You've mentioned cartilage a few times. What gets you excited about that?
Yeah, I mean, I was just so fortunate to I went to hospital for special surgery in New York for my residency, had incredible mentors there, Knicks, Nets, Mets, Giants, docs, and everything in between. And so that was a great foundation. But I took a chance to go to the middle of the country to Rush. I knew that Brian Cole, his team, and many other mentors there who are outstanding, Bernie Bach and others, were really pushing knee joint preservation to the next level, and really learning the fundamentals and principles of what that means. And truly, I think the easiest way for lay people to understand it is what I said before, failed sports medicine, right? So you can also think about it as pre-full joint replacement, right? And so there's this tweener group between the athlete group and the young people with normal joints and the bone-on-bone group that needs joint replacements. And that's most of us, and it's a growing group, and there need to be solutions for that group. And really, we're in the most exponential part of that growth curve, both non-surgical and surgical. So if you think about non-surgical options, that's where all the vogue is about biologic injections, platelets, and bone marrow, and fat, and amnion products. And we are so lucky to be able to study these and help and work with the FDA and, really try to offer our patients new solutions for their osteoarthritis or the like. And so that's one aspect that's very intriguing. At Stanford and other big centers, this space is evolving surgically, and people come from far and wide to get these types of, second or third line, interventions. So growing or transplanting knee cartilage is really an incredible thing. Transplanting in new shock absorbers or meniscus, finding ways to more accurately and less invasively actually change the alignments on the joints. So cut the bones and straighten them and rotate them. And now we have 3D printed guides for this and custom implants. And, the next iterations are coming. They're not all better than the last, and some have stood the test of time. And the space moves relatively slow on purpose, but the problems are there. The solutions are interesting and innovative, and to be a part of that journey for patients and frankly for the world, and to be with that group of collaborators and investigators who are my really close friends and colleagues at big and small centers across that world has been really a big privilege, and definitely an added bonus to the kind of triple or quadruple threat that we have in our practice.
Yeah, man, my next question was going to go one direction, but now you have me curious. So you said cartilage transplant. Mm-hmm. When I hear transplant, I think taking somebody else's cartilage and putting it in, like a heart transplant, right? Mm-hmm. But again, I'm not the doctor on this conversation, so I hear transplant. Well. I think, okay, yeah. Well, I've talked to a lot of doctors. That's pretty much my whole world. So I think, it sounds bad, but like somebody passes away, you snag their knee cartilage and transplant it into somebody who needs some type of cartilage treatment. Is that what that is? Or are you talking like you grab cartilage from somebody's ear and you put it in their knee? Like which way are we going there?
Closer on the first one, but maybe not so far off on the second in the future. There's different tools and techniques. We recently published looking at the evidence for these things, so we'll focus on kind of the big two because that's where most of the evidence has been and what I offer to most patients. The first one is kind of what you alluded to. Someone typically young passes away. There are licensed tissue banks that do harvest their organs and harvest the parts of their knee. And then we match them specifically by age, by location, by contouring to our patients. They get cleared, and we often have to get that transplanted into the patient within several weeks before the cartilage cells become less viable. And so that is one aspect of it. It's a bone and cartilage transplant, more technically called an osteochondral allograft transplant. So that's one thing. You can think of it conceptually as a pothole in the knee joint and a manhole covering that. And so that has advantages because you're transplanting in not just the smooth, beautiful cartilage surface that they've lost, but also the underlying strong bone. So you press fit it in, you can move right away. You don't have to wait for the grass to grow for the cartilage. And so that's why there's an advantage to bone and cartilage transplant. On the flip side, the other big technology is where we actually go in with the small poke holes in the knee. We take a very little biopsy of a non-weight-bearing part of their joint, so we get their cartilage cells. We actually can grow that in the laboratory, put it on a sheet like a membrane, and then come back through a small open incision and implant that in. And the cartilage cells in that environment know what to do. They attach, they start growing their own matrix or surrounds for the cartilage, and they regrow cartilage that's similar to their native. Maybe not perfect, but similar. And so that's called a Macy procedure. So that's the other big one that you might hear of. And then just to close out the thought, there are many other techniques and products out there to restore or regrow cartilage, and many in the FDA pipeline. None to date have withstood the rigor of all the time and evidence that those two have, but we're actively thinking about other ways to go. And so it's not that field is just not all one or none. And if you put 5 of us on a panel, you may get 5 answers. That's pretty typical doctorese, but that's just the world we're living in and the relative kind of uncertainties. And it speaks to taking that individual patient into consideration, and then really it's shared decision making model.
I'm a Kansas City Chiefs fan, so you might know Isaiah Pacheco right now has been out for the whole season with a knee injury. But he's coming back, they said, by the early November. And so I'm just wondering, you probably won't know, but like of those two strategies that you just talked about, which one has the more abbreviated timeline for recovery that maybe he underwent so that he's bouncing back? I think his was, I don't think it was ACL. I think it was meniscus.
Yeah, I think, a key point with our elite athletes in general is that, they are workhorses. They are specimen. Their bodies are tuned to do this, right? And so for us, when they're injured, let's do the least amount we need to do and then get out of their way and let them, be and perform. And so you're often seeing, if it comes to surgery, we're doing the least amount we need to. So that's mostly, obviously, if you have a ligament rupture, you need a ligament stabilized. That's a very common knee one. If you have a meniscus tear, and it's repairable, a lot of the times we can try to fix it. So that might have been, I don't know that specific scenario offhand, but a meniscus repair is another common one, or meniscus trimming if you can't repair it, trim just the damaged portion. Those are more of our standard bread and butter. In the shoulder, the analogy is the shoulder joint pops in and out, so it's unstable. They do a labrum repair, right? So a scope stabilization is a big one. And those are really the mainstay of the treatments for knees and shoulders that we're doing in these athletes. When it comes down to actually restoring or replacing things, the time frames are longer. And frankly, a lot of these tools have not in the past been game ready for impact loading, cutting, pivoting, and sports. So they're really for that former athlete, aging out athlete, transitional athlete. And a lot of the initial things we might do, either, trim a little flap of cartilage, remove a small loose body. Those are things we're doing all the time for athletes. And of course, educating them on how good or not good their cartilage is and the future what if this doesn't work plans, but we're not often implementing them until, a little later on, or until they really know they can't perform, because the timeframes are longer and the percent return is not 100%. And so you might have seen, this is all way out in the public right now, but Lonzo Ball timely just got back, to play recently. You can learn and read about, because public knowledge, the cartilage transplants and meniscus that he had with, my previous mentors. And, that's a long road back, and he hasn't played, I think, in 3 years. And, he had no other good options, and he's going to be kind of a trailblazer. It doesn't mean we're going to do a lot more of those, where it means that these are thoughtful options for those who may not have other options. But in general, we're trying to really, keep it to the straight and narrow, keep to standard treatment pathways and standard timeframes in our elite athletes. And most of them can do really nicely kind of with that approach.
Very cool. That's great insight. I appreciate you sharing that.
I am super excited to introduce to you the Doctors and Dollars 5-Day Financial Challenge. I'm Mike Neubauer. I'm CEO of Grand Vision Companies, and I'm the one that you see on the Wealth Wednesday and Daily Dollar episodes with Nate. So Nate and I are partnering again to do something even more exciting, which is the 5-Day Challenge. We're taking the best of all of our episodes, all of our expertise and knowledge, and we're condensing it into an impactful and purposeful 5-day presentation, 1 hour per day, for 5 days, to give you everything you need to build that foundation for your financial future. So if you're looking to gain the pieces, you want those puzzle pieces and find out how they fit in your financial plan, head over to the Doctors and Dollars website, join us on the 5-Day Challenge. We're putting it together for free, so you got nothing to lose. We look forward to seeing you on the inside.
I want to go a little bit different direction. It's still, I'm going to guess it's more for our aging athletes, if that's the phrase of this conversation. So you mentioned earlier biologics, and I've had orthobiologic experts on here before. Dr. John Santa Anna at the University of Michigan is the one that comes to mind. But can you tell me a little bit more about your research with orthobiologics? I know about PRP. That's about the only one I know about. But I was doing some research on you. There's also bone marrow aspirate concentrate, BMAC, which is, I got to learn about that. But really the idea is, how do you see these types of treatments, the more non-invasive ones, shaping the future of sports medicine?
Yeah, so I think PRP is the most common one. You can take it from your blood, spin it down. We get the growth factors from your platelets. It can be injected in as an outpatient setting. So that's why, rightfully so, that's kind of, the one that most people know of and or have tried. For us, in our research efforts, I think we've recognized that it has previously been kind of the Wild West of indications why you might use it and does it work or not work. And so at least with our athlete population, we're trying to track every single PRP injection that we do. We take a small sample of it so we can quality control it, know what exactly we're giving them, because frankly, not all PRP is the same. The platelet dose matters. And the number of other cells in it matter. So, we want to quality control that aspect, but also know, are we doing it for knee arthritis? Are we doing it for inflammation? Are you doing it for a tendon? What's the age? What's the gender? What's the sport? And what's the time loss? So that's one avenue of just practical clinical research that we're collecting all this information here at Stanford. In the Biologic Association, which is a group I'm affiliated with, there's the BARB group that's doing that at a much higher level across the country. So basically creating what we call a biorepository of the small samples, and also looking at how these patients are doing clinically. So I think we're learning a tremendous amount more. There's safety in numbers there. The larger N that we have and the more data, and then the use of machine learning, you can really find trends that are powerful so that we're not just wasting money and time on the biologics. So that's kind of the big one that we're making, I think, an impact on in the PRP range. Some of the other biologics, like bone marrow aspirate concentrate, that's where you actually can obtain the bone marrow cells either from the hip or different long bones about the knee or the shoulder. And we use different processing centrifuges to concentrate those cells. They have a lot of the similar ingredients that you have with the PRP, but also because they have different cell types. And, it's a misnomer to say stem cells per se. Stem cell truly means that it's going to go somewhere and restore, replace, or regenerate from those cells, like the capacity to self-renew. And really any of the cell-based treatments, at least that we're offering in America, are a little less like one-to-one or linear than that. These cells can be looked at as basically cells that can go to a local environment and help to recruit stem cells from the joints and bones to do their job. They can also help modulate the inflammation in and around that joint environment. And so, I think of the cell-based treatments, like you have a disaster, a hurricane, etc., and we can airlift in the supplies and just throw them there on the ground, or you can land the helicopter with the Red Cross and have the supplies and help the local community to organize and then get out of Dodge. And so that's kind of where I think the cell-based, treatments come into play. Data-wise, head-to-head for non-surgical things, it hasn't really been superior. And so it's hard to tell a patient, go get a big needle in your hip and spin it down and inject it versus taking a small needle in your blood. However, when we're talking about in surgery, that's where I think the biggest impact from these cell-based technologies are, and that's where my research goes. So, for example, with the technology that we just talked about, the bone and cartilage transplants, that cartilage is pristine. It's perfect at time zero, but the bone is dead bone, and that bone needs to be replaced by your own bone for the long haul to support the cartilage surface. And if that process doesn't work, that creeping substitution is what it's called, you have a problem because bone hurts like a fracture. And so a lot of things that plague us there are the bone lacking to integrate. And that's where we sometimes have to go back at a year and change, and MRIs don't look good and the patient's unhappy and we have to drill the bone or do other things. And so to mitigate that, we're trying to find solutions. One of the interesting solutions is actually a couple things, but we basically clean out the pores of that bone better. So we basically, instead of having any residual bone cells from the donor that might react, we wash them out. We actually pressure wash them with pulsed CO2. So we clean the pores of the apartment building to evacuate it. for example, so that it's empty. And then we can load it with things like bone marrow aspirate concentrate. And we've shown that by doing that preparation and then loading, that we can really get this bone pellet saturated with cells and with growth factors that can help to promote healing. And so next step is to show that for sure improves integration and outcomes, and that's ongoing. But it's certainly low-hanging fruit. And when you're undergoing expensive, big salvage surgery, this is not a big ad, and the potential upsides are huge.
Yeah, but it sounds like you're kind of mixing the two, right? You're still doing the surgery that's going to create a maybe not a shorter timeline for recovery, but at least you're getting right in, right? There's not the plasma and the bone marrow that has to kind of morph over time. But what I'm hearing you say is, if you're coming in and pressure wash, I like the apartment analogy there, but coming in and pressure washing, but still using some of that. The bone marrow then I just picture that's kind of like the glue then, so that when you come back in and you actually perform the surgery on the cartilage, there's more cohesiveness there sooner than a bone that maybe, to your point, is dead.
Yeah, I think orthopedic surgeons, we're good technicians. We're good at our jobs in general, but there's a lot behind the scenes and afterwards in healing. And if we can harness the power of biology to help augment any of our surgeries, I think that's where the future of our field is clearly heading. So if, for example, in the future or now, we can do things to get the ACL tunnels to heal better, or that tendon that we put in to become a ligament. Or if we have more reliable ways to take the meniscus repair healing rates from 80%, which is okay, but that's 4 out of 5 people. That's 1 out of 5 that's not going to heal, even if we do the same surgery. That's not great. Yeah. If we can give it a biologic boost with PRP or the like, then I think that's really where the future lies, and that's the promise of orthobiologics in sports medicine. And so it's an active space. The challenges, as you know, this is a dollars and doctors podcast, so you'll probably know more about the dollar side. But there's availability, cost, insurance approvals. So just when the FDA process stops is when the challenges for these novel technologies begin, because it's really sometimes unavailable to patients for quite some time, despite good evidence.
Yeah, and regardless of, some of the hurdles that you just mentioned, I think still your ultimate goal as a surgeon is to just improve the quality of life. And so when you see 4 out of 5 or 80%, like most people see 80%, and they're like, that's pretty good. But in your eyes, you just mentioned it, 4 out of 5, there's that one person whose quality of life is not improved.
Yeah, and we've counseled them the same, and they're sitting in my clinic, and they haven't achieved the goals that we set off to. Obviously, a big part of our job is setting those expectations from the start. So they're always like, "Oh yeah, you told me about that," or "This is how it could have gone." And so, we move forward as a team and we sort through the problem together. But if that's less than 1 out of 5, it's 1 out of 10 or less. That's way better for everybody. Delivering more precise and reproducible outcomes, I think that'll speak to evolving surgical tools and techniques and harnessing the power of biology.
Fantastic insight. That's awesome. I'm going to shift gears on you a little bit. We've been talking about the what I would call reactive care, right? Kind of coming in after something's happened. I like the proactive side of orthopedics as well. So a couple questions that come to mind. The first one that came to mind, just knowing that you're at Stanford, I'm a big college football fan, so you can ask me anything and I'll probably know what's going on. But one thing I do know is the Pac-12 kind of dissolved in a sense. It's still there with 2 teams, but it essentially dissolved, and Stanford moved over to the ACC, the Atlantic Coast Conference, where most of the competition is on the East Coast. What kind of toll does that take on athletes' bodies, like traveling back and forth across the country multiple times during the season? And what are some of those preventative things that they can do to their bodies to keep them in top form?
Great question. Obviously, they've asked that here at Stanford through the transition. We call this the All Coast Conference now. So we've been here, there, and everywhere.
Yep.
Our road trip thus far that I've been on, obviously with them to Syracuse was our first one. We got a road win there, and then down to Clemson, and then a quick turn to Notre Dame. And so, it's been an adjustment. Our school and the others, Cal and a few others, from an administrative and a athletic department perspective, have brought in or had local experts weigh in on everything that you're talking about. And I don't think that there's one perfect or right answer for this. It's being mindful that those problems exist and we have to manage them, right? So things that in preventative care, and this isn't just for these elite guys who need to perform on Fridays or Saturdays, but for everyone, things that we need to prioritize are sleep, right? Getting the appropriate amount of rest. So for them, that correlates to when we leave, when we arrive a day earlier, we acclimate, we fix the schedule around game time and around what we think optimal peak performances are in PST where we're from, right? So that's just one kind of thought and adjustment that really matters. Our nutritionists are always mindful about, obviously you can get dehydrated on long haul flights. So hydration and optimized nutrition, both in the training week and then leading up to games, so they have different regimens, some tailored to the specific athlete, but, some guidelines for the whole group. So obviously keep them well rested and keep them as hydrated and well nourished as possible. These are common sense things, but these are critically important because when you're starting to do these types of, more rigorous travels, you're stressing the system. Those vulnerabilities would count. So you want to basically anything you can control, you try to control in preventative healthcare. And I think those are kind of some of the ABCs of it. Some of the other challenges, just as far as, some of these weeks for us have been shorter than others. So, the practice schedule is just a little more chaotic, right? So figuring that out, figuring out the ramp ups for us when we have injured players and the timelines, if you have a short versus long week, or if we're traveling, we don't always get that extra assessment day before we decide if they're, probable, questionable, doubtful, or out. So it's been a little adjustment on that front. We're making do, but, I think it's just, speaks to the challenges.
Absolutely.
One thing I also would add for not elite athletes, but for us, the lay people out there and people who come to my
aging
office,
athletes.
Yeah, exactly. I think for us, sadly, preventative care, we have to, and I often become a weight counselor. I term it, in the clinic, weight optimization, but load matters, and it definitely matters when you're injured, but it helps to prevent injuries. Each pound can be exponentially more on your knee joint, right? So several times body weight on the knee joint. So for example, if you lose 5 pounds, that's almost like taking a 30-pound book bag and throwing it away. So think about the batters who train with 2 to 3 bats and then they swing with 1. Think about yourself as you're carrying all your kids' stuff up and down the stairs, and then you have nothing. It's just your stuff. That really matters for loads on the lower extremity joints. And so sadly, I'm having that conversation a lot in the clinic, and that's really helpful preventative. Obviously for cardiovascular and other health, it's really important too.
Yeah, that doesn't surprise me at all. We are a nation, unfortunately, of rampant obesity, and even the aging athletes who you look back at a high school picture, you're like, man, you were in shape and you're a pretty good athlete, and now you're 300 pounds and struggling to get down on the floor with your kids. That's tough to see.
Most people, the misconception that I deal with often on this topic is that I need to be able to exercise like crazy to lose weight. And, the reality of the data is that the majority of weight loss is more metabolic, and only a small amount of it, especially as we age, is really that exercise. I'm not saying exercise is not important. It totally is, and low impact exercises and reinforcing healthy lifestyle and for mindset and outlook and being out there. I mean, all those positive benefits of exercise are critical. So it's a component, but you can lose weight on the couch. Most of us can. There are interesting and scientifically driven ways to do that: intermittent fasting, ketogenic diets, other diets, portion control, alcohol mitigation, talking to your primary doc, nutritionist, of course, all the weight loss meds if you're a candidate. And so that helps orthopedic surgeons. It's all like really intertwined with optimizing our outcomes, and also a big part of our outcomes are well-being, right? People need to not only like have a knee that's working or shoulder that's working, but feel like they're moving their life and lifestyle in a positive direction. And these are kind of some of the parallel tools that we use or educate people on to seek help for to do that.
Absolutely. Yeah, that actually reminds me. I was mowing the yard the other day. I have a pretty big backyard, and so I got to throw in a podcast while I'm mowing to keep me entertained. But
it's a very Iowa thing to do.
Very Iowa thing to do. I live like on an acre and a half, so it takes me like 2 hours to mow my whole yard. But I was listening to Joe Rogan's podcast with Jelly Roll. You know who Jelly Roll is, the music artist? So he used to be 550 pounds just a couple years ago. He's down to 420 now. And he was talking to Joe about it. Obviously, Joe's very fit and knows, the MMA and all that kind of thing. And Joe's first question, probably instinctually, was like, well, what's your workout regimen like? And Jelly Roll was like, I haven't really worked out at all. I might shoot baskets every now and then. He goes, I just got a nutritionist and I started eating better. Stopped eating candy in the green room before my shows. I got very intentional with what was going in my body. He lost 130 pounds in the last year. And he said exactly what you said. He's like, my knees feel better. My hips move better. He feels like if I take a deep breath, like just his whole rib cage can like move better, easier, if that makes sense. And none of it, like no exercise. It was all just nutrition.
I mean, I see this day in, day out, and with some of these salvage surgeries that were at the front end of a 2 or longer year initial phase and then a lifelong relationship, I have this hard, and slow and thoughtful discussion about weight. We have to first gain their trust, get them on board, and then I need these tools in my toolbox or I can't win. Like if they're not getting the weight down, I can't help you. It's known in our literature. There's body mass index cutoffs for some of these technologies we've been discussing. Sure. But more importantly than that, you need to start, just chipping away at the things that we can control. And it's the hardest. I mean, I deal with it myself, and I yo-yo just like the rest of us. But when I stick to these principles, develop good habits, I mean, your bodies respond well. And I'm not doing crazy or rigorous exercise, just modest, low impact exercise. And it's symbiotic. They work together, so I think that's just, if people are uninspired, try losing weight on the couch first, then you get down a couple of pounds, then you can start exercising, you'll feel better. And then they work together mostly for compliance. For the longer term, I find that's where the exercise piece helps to reinforce the eating habits and vice versa.
Absolutely. I want to kind of wrap up the being proactive train that we got ourselves on. Like, what advice would you give? There's going to be parents listening to this, not just physicians with kids, but any parents listening. Like, what advice would you give to young athletes, junior high, high school, even college athletes, looking to stay injury free, especially when it comes to like knees and shoulders? Football players, basketball players, tennis, all those more higher impact sports. What are some things that they can do to stay injury free?
Yeah, I think there's a lot of our job is based obviously on evidence, but it's common sense rules and delivering the common sense, rules synthesized from the evidence. So my point is that we need to listen to our bodies, and that pain is not gain. I mean, that concept very rarely holds true in our field. And so parents should be in tune with the young kids' coaches and shouldn't have that kind of a thought process or mentality to just, fight through or push through. There's often a reason for it, right? So some of the ones that are harder are where there's not an obvious, big collision injury. I went from normal to not normal. I mean, that's a trauma that's going to be tended to by a doctor. That one doesn't really go under recognized. The one that's more common is the overuse from training errors and then doing too much. And then those types of athletes can get in big trouble if they don't listen to their bodies, if they don't say something, if they don't get it evaluated and manage that. Those issues can become chronic. They can become actual situations where it breaks down tissue, right, and become cartilage injuries or other injuries. Stress fractures, stress reactions plague our young kids. So I think these are solvable if we know that pain is not gain. It's not just growing pains, and we really need to be mindful of that. Seek specialty expertise. Just back down relative rest. It doesn't mean that we want to keep these kids out for the long term or that they're not going to achieve their future goals of being in the NFL or NBA. If they rest for a week or two now or a month and get better, they'll be able to do that more. And so I think that's a really big one. The other big one that comes to mind in this regard is, there are well-designed injury prevention programs. Now, that sounds boring, so we tried to coin them as sports performance type programs,
Exactly.
which sounds more interesting. They're going to use them to excel, but really using them to reduce their risk of injuries. FIFA 11 Plus, for example, the PEP program, all of these are designed to reduce risk of ACL and other ligament injuries. And the challenges that we face are getting the kids and teams to buy in and comply. We know they work for the non-contact injuries, and those are a lot of injuries, but they only work if you're doing them. And if you're bored or not integrating them into your regimen or training, then they're obviously not going to work for you. And so I think another avenue of research that we're looking into is how we can take next generation technologies and gamify this and make it competitive, make it fun, and the likes. An analogy that we've used is our research teams when I was at University of Missouri and then at Stanford. If you can teach someone like me to use the dance game and learn how to actually, get some rhythm, then you can certainly use a similar, AR, VR, game of sorts to train up movement patterns that reduce risk of lower extremity injury. And that could be kind of fun. It could be a team-based effort. It could be a global effort because they're always competing, on internet-based games, and other avenues. And so I think speaking to this generation and, going right to where they are at, probably harnessing the power of TikTok and the likes, we got to do what we have to do to get the word out there to prevent these industry, but particularly for the parents listening, the young female athletes, these non-contact injuries. I mean, this is an epidemic, and with more participation, it's a growing epidemic. And we can and will kind of take a stand to educate and can prevent some of these injuries because they're life altering, as you likely know.
Yeah, and you got to make it fun. Like, kids these days just want that instant gratification. They can't be bored for more than 5 minutes. Otherwise, it's just absolute torture for them. I mean, we were talking about it offline.
I guess.
Yeah, true. That's true. We were both talking about how we both have young kids, and like they just want instant gratification. So I think you do have to gamify a little bit, but like, because you just can't tell a 16-year-old like, if you go through these programs, it will prevent injuries, which means you play more time. You play more time, gets you more recognition and noticed by higher levels of sports. Like, you got to stay healthy if you want to play. And they're like, that's boring. I just want to go out and play.
You show them the leaderboard, and you give them metric-driven goals, and you make it flashy, fun, and exciting. and available, right? That means portable. That means in their homes or whatever training fields they're at, right? And so, I think there's ways to do it, but we haven't cracked that nut yet, in any standardized way. But it's exciting, and I think it's doable. It's a mission that's worthy of our time.
Yeah. We'll find it. We'll get there. One of these last questions I had to ask you when we were getting this together. This is one of the first questions that I wrote down, but you got a lot of irons in the fire, man. How do you balance the demands of surgery, of research, teaching at Stanford, all the travel that comes with being, the team doc, but also your family life? Like, do you have any routines or practices that keep you grounded?
Yeah, I think, it's family first. So, that starts with Sylvia, my wife, being extraordinarily supportive and understanding why I'm doing each of these things and how they all work together to define my professional life. But that's not my full life. Family matters first. And now that I have an 8-year-old daughter, Evie, a 3-year-old son, as they get older and day in and day out, if they're not good, nothing's good. So that is really the rock. And I think that's consistent, not just for doctors and surgeons, but for everybody. But, you can lose that. And I've seen previous generation doctors and surgeons lose that. A lot of my colleagues from the generation before or above me, their kids ran far, far from healthcare, right? And so there's not as many third generationers like me. And I think I saw that work-life balance, not just passionate for work, but passionate for play and for family, that is pervasive. So things, one, it's not easy. I mean, so it is constantly evaluating that balance and the buckets, what drains energy, what keeps energy, what adds more energy. And so being mindful that burnout actually exists, and that it's not, you don't have to be ashamed to feel feelings that start moving in that direction, but do other things that pull you in the opposite direction. Like going to a course and teaching it for a weekend enriches my life. It makes me feel better about my home life than if I didn't do that course. And when I go and take care of the guys on Saturday, I know you talked about Notre Dame. It was a sore subject for me given our loss last week, but that's an unbelievable experience to share with those guys and to go in the trenches and try to keep them healthy in that environment that's so storied in sports. I mean, that's amazing. And then to come back and do surgeries, and it's an individual one-to-one thing. That really is satisfying. Each and every one of those is different and satisfying, and the like. But again, it's nothing without family. I make time now to try to, at least during weeks and in my routine, to eat healthy myself, to remind myself to do that. I got up at 5 a.m. today in Peloton, right? I try to do that several times a week. When I can, I'm picking the kids up or driving them to school. I'm prioritizing individual time with them. I've brought Evie, loves to come to the training room on Sundays, and she comes and treats the athletes with me and is starting to enjoy, my 3-year-old terrorist of a child. The boy, loves football. What he means by that is just taking a Nerf ball and then falling into whatever's, in and around the kitchen. But, he's understanding that this is a family thing and we're in it together. So I think the more they buy in, the easier it is to do my job. So far that's worked out well. Stanford is pretty big, as is California in general, and just wellness and thoughtfulness about this. So I have sabbatical time accrued actually as a professor each year. I can take some time to either travel to learn a new skill set or just to sit, think, and kind of get things together. So those are all the strategies that I'm trying to employ, but it's not easy. And tomorrow may be just as out of balance as everybody else, but we do the best we can.
Well, what I heard you say, you just have that solid, like it's easy to put family first because your family is just rock solid and they understand what you have going on. But then the constant evaluation, I love that part of it. Like looking at everything that you're doing on a day-to-day basis and saying, is this helpful or is this hurtful to what we're trying to get accomplished personally or professionally? And I think that's something that I do as well as, we try and take on a new initiative within our Grand Vision company or with Doctors and Dollars, and a new idea comes up and it's like, all right, is this helpful? Is this hurtful? Is it going to take up more of my time from family? Or is this something that can easily be integrated into the chaos that we already have going on. And so I think that's super important.
One other thing that comes to mind here, one of my mentors, Bernie Bach from Rush, surround yourself with excellence. I mean, just don't be scared and don't have to, be competitive with those who are in your immediate environments. Everybody can rise up together. And if I have excellent partners, excellent clinical, excellent research collaborators, the team that we've assembled is excellent, then I'm inherently going to be pushed to be better and to be excellent. And frankly, if you take that mentality, it only drives you forward. And if you have that mindset or mentality in sports medicine or in anything of being really skeptical of others or really trying to, put yourself up at their expense and not valuing the team, I just think, one, it'll be a lot harder to go through your grind, and it seems like a tough way to live. But two, you're not going to be able to improve yourself. And so there's always tendencies that you don't want, competitors around or this and that. I accept that and then run like head on to it. And I'm like, let's do this. If this person is so talented that they make me up my game and rise, then we're going to rise together. And that's super exciting. So, that's a mindset and a paradigm that I think has served me well.
Absolutely. The way I always wrap up these fantastic conversations, what do the next 5 years look like for Seth Sherman?
I think continuing to critically evaluate each of these buckets, right? The clinical aspect of my job, the innovation aspect, the teaching, the team coverage, and weighing all those things in light with the work-life balance aspects. I'm a huge, also, I didn't tell you, fly fisherman, so that more fly fishing this next 5 years.
I was just in the Tetons a couple of weeks ago, so.
Excellent. So, we can totally trout fish together or tarpon or whatever you want to do. But that's another aspect of the burnout or the work-life balance that's critical. So, finding and protecting time to do those things. Look, I just want to look forward to Mondays. I want to continue to be passionate in my approach to sports medicine. I want to be excited about what the future holds. And so for me, being at this, incredible, large and bureaucratic academic institution, it takes time to get things done and to find your footing. And so I've been here 5 years and change. This is, this next chunk of 5 years is a great time to really solidify all the, the things that we've started and then try to take things to the next level. I think professionally, continuing with the bread and butter sports medicine, knee and shoulder stuff, but really trying to work with team members here and elsewhere to dial in the knee joint preservation aspects and cutting edge technologies, really delivering impactful treatments to more patients and helping to bring the general sports docs up to snuff on some of the technologies we already know work. So I think that's an exciting mid goal. I think probably these are just more big picture things than anything, but no major or drastic changes, really just kind of evaluations and refinements of the buckets I've established.
Absolutely.
Fun fact there, Nate. I'm getting old, and I just thought about this and freaked myself out in clinic the other day. In 2030, I'm going to be in practice 20 years. So that's not training, that's practice. So, it's crazy how time does fly, but every case and every day I'm learning something new. I critically evaluate myself, my team, our processes on the regular. I think if you don't, you become stagnant. And so, that's just a consistent thing that I've learned to do that's really served me well.
Hey, as long as you followed up that shock factor of 20 years with a sense of pride, because that's certainly something to be proud of to make it that long in practice. And be so successful. Cool. That's very cool.
Thanks, man. 15 now, but 20's coming.
There you go. It's coming. You're rounding third base to it. Well, I appreciate you taking some time out of your busy schedule to hang out with me, Seth. And I look forward to when our paths cross again in the future.
Yeah, it was fantastic. And you have a great day. I'll come visit you in Iowa, not in tornado season. I'm petrified of those.
And I will come out to Northern California anytime because you guys got it made out there with weather.
Excellent. Perfect, buddy. Thank you.
Yep. See ya.